to intubate or not to intubate. Generally, whenever we think of any patient who we have to manage the airway, or the airway is at compromise, there is some vomitus, there is some secretion, or there is impending airway. So in that situation, there are you have to ask these 6 questions, like, can the patient maintain an airway? Will the patient will be able to protect his airway or not? And the patient, if we have properly kept the done the intubation, is the patient appropriately ventilating? Is the patient appropriately oxygenating or not? And is the patient condition likely to deteriorate? And is the scene appropriate, safety, and moving the patient while the patient is apneic? Purpose of this presentation is to familiarize all of us with the medication used of our RSI procedure, recognize when to do the RSI and when not to perform, and what should be our backup plan. Quickly, talking about RSI, it is rapid sequence intubation. It is the near simultaneous administration of neuromuscular blocking agents and sedative hypnotic drugs in order to facilitate oral intubation of a patient, with the least likelihood of trauma, aspiration, hypoxia, and other physiological complications. The indication could be immediate severe airway compromise in context of either it can be due to trauma, it could be because of a drug overdose, it could be because of the status epilepticus, or where respiratory arrest is imminent. Indication would be, condition requiring oxygenation, ventilation, or positive pressure ventilation, like traumatic brain injury with loss of consciousness, severe thoracic trauma, having flail chest, pulmonary contusion with hypoxemia, or where the clinical condition is expected to deteriorate. Any patient who is unconscious with potential for or actual compromise or vomiting, and a patient has a clenched jaw or an active gag reflex. Other situation where RSI should not be done is where the patient is spontaneously breathing with adequate ventilation and oxygenation, where we can go ahead with our NIV or BiPAP support. Operator concerns that both intubation and bag mask ventilation may not be successful due to major laryngeal trauma, upper airway obstruction, or distorted facial or airway anatomy. Or the person who is going to manage the airway or going ahead for the intubation is not familiar with the medications, or the person is not familiar, well versed with the procedure, or the patient is a candidate for CPAP. Most important complication because of going ahead with RSI or doing intubation could be increased ICP, increased IOP, that is intraocular pressure, increased intragastric pressure, aspiration due to decreased gag reflex, malignant hyperthermia, that too in patients who are predisposed or where medications are used like succinylcholine, dysarrhythmias, hypoxia, airway trauma, failure to intubate and failure to ventilate, where your backup plan should be in place, and probably death if the person is unable to intubate the patient. Assumption, what you have to think is the patient has always a full stomach and operator can secure an airway. Failure, if you fail, then that will be the death of the patient. Do not take away what you cannot give back. The operator can resuscitate the patient. So all these 3 are major assumptions. Yes, the patient has a full stomach, I can secure the airway, and I will be, if there is any arrhythmia or there is any complication, I'll be able to resuscitate the patient. So at least these 3 should be in check, and a backup plan or a backup anesthetist or a senior person should be available, involved in the in the process of intubation, and what equipment we need to get it ready. Now, difficult airway is always something which one should anticipate, and the failed airway is always which one experiences. Now, if you look into this slide, there's a picture where there is a trauma patient, there is facial trauma, there is neck trauma, and there's a lot of blood. So we assume there is facial, this is head injury patient, and you might have any facial or the neck trauma. Now, identifying a potentially difficult airway is essential for preparing and developing a strategy. So if in this patient you can see that the person is the doctor is trying to intubate a person, and if there is a lot of edema inside, it could fail into it could lead into a failed intubation. So alternative would be, going for a cricothyrotomy, or before that, bag box ventilation, preparing everything. Now, some predictors of a difficult airway would be where the person's C-spine is immobilized, like in trauma patient, the trunk is too big, it's protruding, the neck is too short, it's thick neck, prominent upper incisor, what we call as buck teeth, receding mandible, high arched palate, beard or facial hairs, because that cause difficulty in bag mask ventilation, artificial dentures, limited jaw opening, limited cervical mobility, because definitely you have to do a head tilt tension lift in a non-traumatic person, upper airway conditions, any face, neck, or oral trauma, laryngeal trauma, airway edema, obstruction, or the patient is morbidly obese. So these are your, some of the predictors that which tells us that the patient will definitely have a difficult airway and your backup plan should be ready. Additional predictors in the term of medical history would be like patient having a joint disease, acromegaly, or there was any thyroid or major neck surgeries, there is any tumor or known abnormal structure, no genetic abnormalities, epiglottitis, where definitely you expect there is some swelling inside, there is some inflammation inside, pregnancy, because of the fluid collection, everything gets swollen up, obesity and pain issues. Now, our objective is first to identify four areas of airway difficulty. Like if I go ahead with a bag mask ventilation, will I find it difficult? Like, is there any difficulty in bag mask ventilation? Okay, so that is the first one. Then if I put in a laryngoscope, will there be a difficulty in laryngoscopy? Or if I put in a tube, will there be any difficulty to put in the tube, like difficulty to intubate? Or there is a difficulty in performing cricothyrotomy. Now, predicting a difficult airway, always you have to use the mnemonics like bones, lemons, and DOA.